evening, friends, and happy Navaratri. Today is the last day of auspicious Navaratri, and post this session, I'm sure you guys will be enjoying Navaratri and doing garbas and everything. So, I welcome every single individual this evening on behalf of Indian Cancer Society to our exclusive show Fridays with Shrenik. We have very specific purpose for streaming live webinar by inviting the top of the line cancer super specialists to this platform for sharing their knowledge, experiences, expertise, and last but not the least, addressing all your queries during the webinar. And we have specific reason for addressing Q&A session for simple reason, like these cancer specialists, they have their own priorities, and they cannot answer all your questions during the private consultation. So we are taking this opportunity of getting you updated with the knowledge. Now today we have a very important esteemed and dear friend of mine, Dr. Ashish Kaushal, medical oncologist, a person completely down to earth, and not only that, is always ready to support cancer patients and caregivers at any given point of time. I know him for at least last 10 years, and I am super excited to welcome Dr. Ashish Kaushal, medical oncologist, and I must say that he has played pivotal role in saving lives of too many cancer patients as a medical oncologist by suggesting chemotherapy, early detection, and whatnot. And the most interesting part is, his approach is absolutely crystal clear like water. And I'm sure you guys will enjoy listening his knowledge, expertise, and experiences. And yes, all your questions will be answered. Welcome you, sir, Dr. Nathan, and stage is all yours now.
Thank you, Shrenik bhai. Thanks for everyone for the joining. And first of all, I would like to thanks to Shrenik bhai, who is giving me this opportunity to meet you all these people on virtually. And thanks for his kind words. We are doing a lot of events together, and this is the event which we are hosting through Indian Cancer Society first time. And I hope this session will be fruitful for everyone. And October is the breast cancer month, and in this month we usually discuss about how we can reduce the incidence of the breast cancer. Every year there is a different theme. So diagnosis of breast cancer in a pre-cancer or early stage, and definitely it's improved the outcome of all the patients. Unfortunately, in our country, majority of the patients are diagnosed still in advanced stage. So there is a lot of need of diagnosis of the cancer in the early screen stage, where we can treat with the very curative stage, even with the pre-cancer stage. So I think with this small background, I would like to give some of the brief information of the cancer per se, the breast cancer, what are the incidents, how are this cancer spread, what are the treatment options, and your modality of the treatment, where we can reduce not only the patient's suffering, but also improve the quality of life of the breast cancer patient. Now we have a different tools in our day-to-day practice, and of course, in 2024, we have a very newer advances, so we can definitely give not only the curative treatment to the patients, but as well as we also look for the quality of life questionnaires, and we can give the good quality of life for the patients, especially for the breast conservation, and we can treat with the minimum side effects with the current tool. So let me first share my screen, and we'll go through with the basics and what are the newer updates in the breast cancer and in the era of 2024. So as we know, the cancer is not a outside disease. It's not a communicable disease. This basically uh, it's an abnormal proliferation of our own cells. So when any cells in our body is beyond our control, that's abnormal growth of the cells leads to cancer. And it's a process. It's not developed suddenly. It takes few days, months, and years. Depends how aggressive is the cancer. So initially, the cells become abnormal, they become unregulated, and the overgrowth leads to the formation of tissue, tumor, and then this tumor will spread either directly to the surrounding organs, later on with the lymphatic channels and the blood vessels to the different part of the body. So the cancer is basically, it's not any outside disease, it's our own cells which are uh, their growth is uncontrolled and they are not in regulation by our own body control. As far as the cancer in our country is concerned, in a female, the breast and the cervical cancer is the most common cancer. After that, there's ovarian cancer, uterine cancer, head and neck cancer, lung cancer, and colorectal cancer are the other cancer. The incidence of the breast cancer in our country is still rising. It's alarming. Though the cervical cancer incidence has decreased, ovarian cancer is also one of the concern. Rest of the cancer is related with our habits also, like head and neck cancer and the lung. So today we are discussing about the breast cancer. As far as incidence of the cancer burden, we have a global count data of 2020. The breast cancer constitutes the highest number of the cancer in the women. That is, compared to all the cancer, it is around 13.5%. So currently we have around 18 to 20 lakh cancer cases are diagnosed every year. In women, this is the most common cancer. Another important thing is the cancer is not only limited to the women. This can be in the male patients, and where it is usually associated with some kind of the family history. The incidence of cancer is increasing. At the same time, the death related to the cancer, unfortunately, is increasing. And there is a lot of unmet need to control the cancer and also to improve the outcome of the cancer and to reduce the mortality of the cancer. So in women, breast cancer is very important. Unfortunately, as I mentioned initially, many of the women are diagnosed in its advanced stage, that is stage 3 and 4. There is unmet need. The cancer should be diagnosed in early stage, even the pre-cancer stage. Many of the cancer are actually preventable. 30 to 50% patients, this can be diagnosed in a pre-cancer stage, even early cancer stage. So in the women, the cervical cancer, by doing a regular pap smear, it can be diagnosed in the pre-cancer stage and even early stage. While breast cancer, by doing a regular mammogram, we can diagnose in the pre-cancer in early stage. So this is the two cancer in the women, the cervical cancer and the breast cancer is definitely there is definitely guidelines for the cancer screening and which should be done in a different age group patient. So why we are talking about the breast cancer? Because this is the most common cancer in the women. And there is a chance of 1 in 7 of getting the breast cancer in the women. And 1 out of 33 women is going to die from the breast cancer. So this is one of the most common cancer. With the current modality, the treatment options, newer drugs, surgery, radiation, immunotherapy, target therapy, now we have a better tool to control the cancer. So if you see about the mortality related to the breast cancer is actually improving. It's going down. And that is basically for early detection in the improved treatment. But still, the incidence is, is still high. It is one of the most common cancers. The most common symptom for this breast cancer is a lump in the breast or armpit, either nipple retraction or bleeding. So that can be very easily diagnosed in the women. But the limitation in our country, many of the women, they shy, they don't then show this lump or their swelling to the local doctor, and that leads to the late onset of the diagnosis and advanced stage of the diagnosis of the cancer. So the breast cancer is basically a the cancer in our breast. It is a gland which is found in the chest, and it has a basically lobules, duct, fat, lymphatics, blood vessels, nerve, and the connective tissue. And the lobules, which actually produce the milk, and with this small tube, which is called duct, that connects the lobule and drain milk to the nipple. And beyond surrounding that, there is a muscle rib. And the cancer which arises from the lobules is called lobular carcinoma. And with the cancer which arises in the small duct, which connect lobules and the nipple, is called ductal carcinoma. So majority of the breast cancer actually are the carcinoma. There are the certain benign tumor of the breast also there, which could be a fibrous tissue like fibroadenoma, fibroadenosis, sometimes simple uh, 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 fat collection, lipomas, even with some infection, which is called brain abscess, if there is some blockage of the duct. So these are the benign situation, but in the old age group, the majority of the tumors of the breast are actually they are the carcinomas. There are the definitive guidelines where we can screen for every woman for the breast cancer, and that most of the guidelines, including the our country guidelines and the US guidelines, they suggested screening of every woman after the age of 40 years and older. And what are the screening tests to be done? Is a yearly mammosonography. So mammosonography means the sonography of the breast as well as with the X-ray of the breast. There are also yearly clinical breast examination by a local doctor or oncologist or any breast specialist is also useful to diagnose the cancer in early stage. So for screening, we need to do yearly mammosonography and a regular clinical evaluation after the age of 40. That is for normal individual. Between the age of 20 to 40, there are some recommendation of regular breast examination every 3 years. But in high risk situation, if there is a family history of the cancer, I think that screening comes a little early. If somebody is having the cancer at the age of 40, their first degree relative should start screening 1 decade earlier, that is the age of 30. Any age, if there is somebody is having any abnormal lump growth, they should consult a doctor immediately, and we can definitely look for any benign versus malignant condition in the treat. So any of the abnormality of the breast should be reported to the clinicians immediately. And as far as the age group, as I mentioned, after the 40, we need to do a regular mammosonography to diagnose the cancer in the pre-cancer in the cancer early stage. There are various risk factors for the breast cancer, and that could be genetics, like some mutation. These are the hereditary mutations. The name is BRCA1 and BRCA2 mutations. And hereditary mutations are there in around 5 to 10% of the breast cancer patient. That leads to cancer in the family, and even the next generation are at risk of the cancer. And these mutations actually not only increase the risk of the breast cancer, they are associated with the risk of the other cancer, especially with the ovarian cancer, prostate cancer for male patients, male breast cancer, pancreas cancer. So these are the other cancers which are associated with these mutations. Other risk factors are actually associated with the exposure to the estrogen hormones like early menarche, late menopause, late pregnancy, nulliparity, no breastfeeding. So these are the factors which are associated. Any family history there, you are at more risk. Hormone replacement therapy, especially for more than 5 years, treatment with the radiation in a young age group, any addictions, longer addiction of there's some association with the smoking, alcohol, and obesity. So these are the basic risk factor. And out of that, the hereditary breast cancer and the exclusion exposure is the most common associated with the breast cancer. As far as the genetic is concerned, 10% of the breast cancer actually they are inherited. They have associated with the family history. And out of that, the most common abnormal mutation is the BRCA1 and BRCA2, which increase the risk of the breast cancer and ovarian cancer is around, and that leads to the risk of cancer is around 40 to 80%. With the using our newer diagnostic tool like next generation sequencing, we can identify the other mutations like ATM, CHEK2, PAL-BT, PTENS, STK11, TP50. These are the different mutations that are also associated with the some breast cancer risk. But out of that, the breast cancer risk are more associated with the BRCA1 and BRCA2, which is one of the most common risk factor. How to diagnose the hereditary breast cancer? Because we have seen a lot of cancer now in the young women. And whenever there's a cancer is diagnosed in the young women, there are the strong association with the hereditary breast cancer. I think the clinician or the treating oncologist should not ignore of diagnosing any hereditary breast cancer. The recommendations for the breast cancer hereditary testing is basically if there is a breast cancer is diagnosed in the young age or there is strong family history. So how we can diagnose? By doing a simple test. It's a blood test. And like as I mentioned, next generation sequencing NGS, or where we can check for various hereditary cancer mutations, especially for BRCA1 and 2, by doing a blood test. And usually in 7 to 10 working days, and this genetic lab gives the results, and we can diagnose whether the patient is having any genetic mutation or not. And if the patient is having these mutations are positive, their first degree relative should be look for this testing because there can be a carrier, there can be a positive for the hereditary mutations, and there are the definitive guidelines for their screening or prophylactic surgery if one of the family members. So suppose the mother is having the breast cancer and she's positive for the BRCA mutation, her treatment is going to be modified based on the mutations, but as well as their first degree relative, their sister, their daughter, and son, they should look for the testing for this mutation. And suppose if the daughter is positive for the BRCA mutations, she also require a regular screening or prophylactic surgery after the certain age group when she crosses, and that probably leads to prevention of this cancer. So testing of useful if there is family history of breast cancer, ovarian cancer, or especially if the cancer is diagnosed in the young age, particularly in the age less than 50 years. There is a one type of the breast cancer. It is called triple negative breast cancer, which I'm going to discuss later. This is most commonly associated with the hereditary breast cancer. And if somebody is diagnosed the breast cancer at the age of less than 60 years, and if she's having a triple negative breast cancer, I think she should screen for the hereditary breast cancer. So, what are the symptoms of the breast cancer? As basically is the most common lump you can see in this image. Nipple discharge, dimpling, breast or nipple pain, nipple retraction, some redness of the skin, which is longer association duration, changes in the skin texture, any lymph node enlargement, any abnormal swelling of the breast. So all of these symptoms are associated, and especially if the age is more than 40, we should consult a local doctor and look for the screening test for the breast cancer. Various diagnostic tools are available, but most common thing is the clinical examinations and the mammosonography, which is most common. There are the various tests are available. After there is a suspicion of the breast cancer, then it can be done a biopsy. They can look for the hormone testing, target testing, and to look for the metastasis. So whether this cancer is limited to the breast or if spread in a different part of the body by doing a CT scan or PET scan. So all these other tests are there, but the most important thing is the clinical examinations by an oncologist or breast specialist and mammosonography, which should be a minimum test. So this is the one of the image of the mammography. You can see the breast screening has been done by taking an X-ray of the breast into two different view. That is, one is craniocaudal view and second one is the medial lateral oblique view. And you can find out the breast lesion in somebody is having the suspicion of breast cancer. Another test after that is if there is a suspicion in the mammography, you can get an MRI done, which is more specific. So this is the basic test for the cancer screening. There are the different newer tests are also available for the screening, but the most common is the mammography. There are the thermal screening. There are the various newer updates. but in our country, the mammography is widely available. Based on the tumor site, we need to classify the breast cancer, and we need to stage and grade, and we need to prognosticate based on the hormone receptor status in the breast cancer. They're all useful in the cancer treatment, and the clinical oncologist will decide the further workup and later on treatment based on this workup. So this is the common type, as I mentioned initially, the breast cancers arise in the duct. It's called ductal carcinoma, and those are the lobules. It's called lobular carcinoma. But there is a pre-cancer situation. It's called ductal carcinoma in situ and lobular carcinoma in situ. So which is a pre-cancer. So you can, if you diagnose the cancer in early stage, so we can treat in a very curative intent. On more aggressive type, it is an inflammatory breast cancer, and the biggest disease of the nipple, which is causing the nipple retraction and discharge. So majority of the breast cancer is actually ductal carcinoma, which is around 80%, and around 10 to 15% of the lobular carcinoma. There are the other type of the breast cancer. So this is the general view, and there is a rare type where there is a papillary basal type, lymphoma, mucinous, and medullary tubular carcinoma. These are all the other rare type of the cancer. So breast cancer has been grade, whether it is grade 1 to grade 4, based on the how it is aggressive. So if the tumor is very defined and low aggressive, it is called well differentiated. And if it is very, very aggressive, it is called undifferentiated tumor. It is called grade 4 tumor. The biology of the breast cancer is based on the hormone receptor, which is to be done by ER/PR testing on the biopsy of the tumor. So once the tumor has been suspicion, the oncologist get a biopsy of the breast tumor by doing a needle biopsy, and the subject this tissue for the laboratory for the histopathological evaluation and for the ERP and HER2 status, which is mandatory for all patients because this ERPR is basically hormone receptor and HER2 is basically a target receptors. And they are basically diagnosed on the immunohistochemistry, which is a test to be done on the biopsy, core biopsies, and that helps in the diagnosing whether this patient is hormone receptor positive breast cancer or hormone receptor negative breast cancer. So similarly, HER2 status has been defined by doing an IHC test as well as the FISH test, which is called fluorescent in situ hybridization. So not only the diagnosis of the cancer is important, we need to look for the biology of the cancer, and with this testing, which is called, we can define the breast cancer in the various subtype, and which is called a molecular subtype of breast cancer. So previously, we decide the treatment based on the stage of the breast cancer, but not now. We decide the breast cancer beside the stage. We need to look for the biology of the cancer, how aggressive is the cancer. So there is a various type like luminal A, luminal B, HER2 positive, and triple negative breast cancer. So luminal A is the most common type, which is a strong hormone positive patient where the patient is HER2 negative. While luminal B is a hormone and positive, but there is a more aggressive biology. It is called Ki67, which is high. So this is more aggressive. And HER2 new is also more aggressive where the HER2 receptor is positive. And this cancer is require a special treatment. Not only the chemotherapy, we need to give the targeted therapy. And triple negative is the most aggressive cancer. As I mentioned initially, this cancer is associated with the hereditary cancer. So we need to look for the mutation testing for hereditary test, and because if the patient age is less than 60 years. So this cancer is basically ER and PR, which is hormone receptor, and HER2 negative, which is around 15% of the cancer in the breast cancer, and it is a worse prognosis. HER2 expression, which is there around 15 to 20% of the cancer, it is also aggressive type and it's a poor outcome. But with the availability of anti-HER2 new monoclonal antibodies, now the outcome is better. So we can use this anti-HER2 new monoclonal antibodies, which is called biological therapy. We can treat this cancer with a very effective way nowadays. So staging, as the cancer spread, it start from stage 1 to stage 4, which is unusual. And you can see in this graph, this is the common metastatic site. The breast cancer is spread from breast to the axilla, which is armpit. And from there, you can go for lungs, liver, bones, brain, and different part of the body. So most common spread of the tumor of the breast in the armpits, and then liver, bone, lungs. These are the common sites. And more metastasis leads to the poor outcome. Coming to the management, so once we diagnose the cancer, uh, we need to do a biopsy for the confirmation and look for the ER-HER2, as I mentioned, what is the biology of the cancer. And we need to do a scan that is called either X-ray, sonography, mammography, CT scan, or PET scan to look for how the cancer is spread, whether it is limited to the breast, whether it is spread to the armpit, or whether it's spread to the different part of the body, as I mentioned in the previous image, whether it's spread to the lung, liver, bone. So that defines your stage. And if the cancer is limited to the breast, then the treatment is different. If the cancer is spread to the different part of the body, then it is called a stage 4 cancer. Then we need to treat with the medical management of those patients. So these are the various treatment options of the breast cancer. The first one is the medical management. It's a neoadjuvant and adjuvant chemotherapy. Surgery are the other option. Radiotherapy, hormone therapy, anti-HER2 target therapy, as I mentioned initially, neo-targeted therapy, immunotherapy. So this therapy is useful for each and every patient based on their stage. It's not necessary this all patients require the similar treatment. So majority of the patients require more than one therapy. And based on the biology of the patient, stage of the patient's patient preference, we need to decide the patient treatment option. So if the cancer is limited to the breast, currently the breast conservation surgery is the most common surgery is performed. Previously, the removal of the breast, which is called mastectomy, is nowadays gone down, and everybody is preferred breast conservation. So breast conservation is a common surgical treatment as of now. We have a various newer tool. Similarly, the radiation, we have a newer machine for breast cancer patient who having the tumor is large, more than 5 centimeter. If the tumor is spread to the armpit, which is called a lymph node metastatic patient, or breast conservation is there. In this situation, the radiation is to be given. While the chemotherapy, hormone therapy, anti-HER2 therapy, target therapy, immunotherapy is given in a scenario based on the patient's different biological profile. So if the patient is hormone receptor is positive, if the tumor is large, tumor is spread to the lymph node, most of the patients require chemotherapy treatment. If the patient is hormone receptor positive, they require hormone therapy, which is called ERPR positive. If the patient is HER2 positive, as I mentioned, is aggressive biology, we need to give anti-HER2 therapy, and this is injectable treatment for a year of therapy. Some patient, we need to give the neo-targeted therapy, which is available in the tablet form, along with the hormone therapy in a high-risk situation. So these therapies to be given to prevent the relapse of the cancer patient. And immunotherapy is a newer treatment options currently is come in the cancer management. And this immune therapy is basically activate our own immune system. Like in cancer, there are the certain immune pathway where our immune system is become weakened. And with this therapy, the immune system is become activated in our own T lymphocyte, which actually works and efficiently and kill the cancer cells. So immunotherapy is a new era of the treatment and which is recommended in the triple negative breast cancer, which is the most aggressive variant of the breast cancer. So different therapies to be given, and sometime what happened because in our country we have seen a lot of patients the tumor diagnosed in advanced stage and tumor is quite big where the surgeon cannot remove or we need to do the breast conservation. So we need to give the chemotherapy to downstage the disease, which is called a neoadjuvant chemotherapy. So neoadjuvant therapy is basically the therapy which is to be given before the surgery to reduce the tumor size. The intention of this neoadjuvant therapy to downstage the tumor, which helps in the surgeons to remove the tumor with a clear margin, and that also facilitate the breast conservation in borderline situation or even those situations where it won't be possible initially. So with this neoadjuvant therapy, we can definitely perform a less aggressive surgery. Even we can improve our breast conservation rate. Adjuvant therapy is basically for those patients where initially the surgery has been performed, and after that the chemotherapy is given to eradicate the micrometastatic. There is a certain microscopic disease which cannot be removed by surgery, which are there in the blood cells, lymphatic channels, even the local site. To prevent the recurrence of the disease, this treatment is to be given, which is called adjuvant therapy, and this therapy is basically used with the chemotherapy, hormone therapy, target therapy, biological. So all the options are there based on the patient case to case, based on the hormone receptor, target receptor, and the risk of the patients. We need to give this adjuvant therapy. So in each and every breast cancer patient, there is no uniform treatment. Based on the individual patients, we need to decide the treatment. So we can say the treatment is not general. It is more personalized for giving a optimal outcome and the best outcome for the individual patients with the modern therapy. There are the certain side effects, and I think this is a very important aspect of the breast cancer treatment because a lot of treatment is associated with the side effects, and which is very much concerned, and everybody is afraid regarding the chemotherapy side effects. And certain side effects, which is common side effects, is a nausea, vomiting, some reactions, weakness, fatigue. With the chemotherapy, there is a bone marrow suppression, which is called neutropenia. If the WBC count go down, then the risk of infection, the patient having fever, mouth ulcer, diarrhea. There is some skin pigmentation, some neuropathy. The patient may complain of tingling, numbness. And one of the most important side effects, which is the people are afraid of chemotherapy, especially in the breast cancer, is the hair loss. It is called alopecia. So the most common and the effective chemotherapy of the breast cancer actually may they cause the complete hair loss. And this is one of the major concerns when we counsel most of the patient about chemotherapy treatment. There are the immediate question arise regarding the hair loss. So people are afraid, and I think in the current uh, era we have some device which I'm going to discuss, and so that we can minimize this risk, and of course which is useful for many cancer patients, especially for breast cancer, and which is called scalp cooling device to prevent the chemotherapy induced hair loss. So basically the chemotherapy terms what is very much notorious sometimes because they believe the patients feels their health will be completely out, and they disclose their identity to the world that they're having the cancer, and hair loss during the chemotherapy is one of the most traumatic experience in the patient's life. And we have seen the patient who refuse the chemotherapy of because of the fear of losing their health and the cosmetic outcome. So this is a very important side effects. And you can see there is a different grades of the alopecia. Grade 0, no hair loss. Grade 1, up to 50% of the hair loss, no wig is required. And grade 2 is more than 50% hair loss, where a wig is required. So breast cancer chemotherapy, if we give, I think all the patients, they develop more than grade 2 hair loss, so more than 50% hair loss. So this is the current device, calculating device, which is very important. And how it works, basically, it is a cap which having the temperature regulation, and this controlled regulation helps in the preventing the hair loss because the drug which attack the hair follicles, which is one of the rapidly growing cells, and also the cancer cells. So it kills by doing the chemotherapy effect. But when the patient wear this scalp cooling therapy, with the Cephra vasoconstriction, the supply of the blood to the hair follicle has been compromised, and this to be where during, before, and after 60 minutes of the infusion of the chemotherapy treatment, so that all the circulated drug is to be washed out, and this helps in the preventing the hair fall by the cool temperature that causes the blood vessel to the shrink. So this is basically useful for not only the breast cancer, other solid tumor patients which will require a chemotherapy agent, especially with the taxanes, alkylators, and even anthracycline. But this is not useful for the blood cancer patient because they require a very frequent cancer treatment. So wearing this cap for regular intervals is very risky because it's there's a wearing the cap at this temperature may lead to some headache, nausea, vomiting, and the skin pigmentations, frostbite. So we need to use for this is mainly for solid tumor, and leukemias and lymphomas require regular chemotherapy. How effective it is, the level of success depends on the many various factors, the chemotherapy protocol, post-hair scalp cooling, and how your scalp temperature is maintained during the treatment phase and the care of the scalp. And this is effective approximately 50 to 70% of the patients. And even with the taxane-used chemotherapy, we have the success rate is around 80 to 90%. So it's very effective, and most of the patients of the breast cancer and ovarian cancer, they are definitely useful this patient. And there are the certain side effects, but which can be minimized by doing a certain preventive technique, like we can use some uh, uh, bridge therapy, where we can avoid the direct exposure to the skin, which covers the forehead part. Sometimes patient feel headache, we can give the paracetamol. So maintenance of the care throughout the treatment, which is also helpful, and most of the patient can complete without major issues. So this is the machine where the patient can wear this cap, and this is one of the images of scalp cooling center where the patients pre treatment here, and after the sixth cycle, another image, the patients receive first cycle, third cycle after that. So we can definitely prevent the hairs in most other patients, especially the patients are taking chemotherapy with the solid tumors. So what we can conclude, not only in the advancement in the cancer treatment, we have a latest surgery, radiation tool, newer medical management. Also, we have a newer advantage in the quality of life of the patient. So we have a scalp cooling device, we have a better anti-emetic drugs, we have a better growth factor. We can give the very aggressive chemotherapy where the patient side effects can be minimized. So I think not only the cure, but quality of life is also matter, especially for the breast cancer patient, because uh, this is the very important part of the social life. So minimizing the side effects also helping in the patient can cope up with their society, and they can live with the self dignity. With this, I thanks for everyone for warm listening, and I hand over to Shrenik bhai. I hope there will be a lot of questions where can we I can definitely try to answer.
Yep,
Thank you.
sir. Thank you very much. I must say that in last 30-35 minutes, you shared the entire alphabet from A to Z about breast cancer, right from introduction to the treatment protocols to hair loss and everything. And you're presenting these slides, these everyone a lot of clear impression to every single attendees, and that is, I believe that that is the major breakthrough we got today. Now, dear friends, we at Indian Cancer Society, we are not medical professionals at any point of time, but we are using our acquaintances with the best of the best cancer specialists across India, and we invite them for delivering their talk, knowledge, sharing their experience, expertise, and these are rare information you would be getting through this webinar. And by any chance, if you are browsing any details on the internet, you won't be getting such clear and precise information which Dr. Ashish Kaushal has given today. So, sir, thank you very much for your candid uh, knowledge and experience and expertise shared by you together with these slides. And I am sure all attendees must have been benefited like anything. Vishali, let's open the session for Q&A.
Sir, as of currently, we do not have much questions in YouTube. They have just written their names and that they are from this college attending the session.
Okay, Ashish, I would like you to throw light much more about recurrent cancer. I mean, recurrent breast cancer, because that is quite alarming situation for, I mean, whoever is got diagnosed with this cancer, and despite surgery, chemotherapy, radiation, and everything, the stages are changing, and that is always a fear of recurrent cancer and spreading to other organs. I would like you to share your thoughts on this.
Absolutely. I think this is one of the major concerns when the patient is diagnosed and treated with any kind of cancer, not only for breast cancer, because recurrence of the cancer, not only locally as well as distally, different part of the body, is is a concern. I think the recurrence rate of the cancer is depends on the multiple situations, not only the patient factor, also as the physician factor. The patient factor is the how aggressive is the disease, what are the stage where the patient is being diagnosed, how late patient presented to the treating doctor. That all things are important. At the same time, the patient who received the treatment with the optimal treatment protocols, standard of care, and of course they receive whatever the best, and nothing is to be missed. That is very important. And of course, at the end, the regular follow-up, because what happened many times, the patient who receive treatment, but they don't come for the follow-up, because follow-up is also very important, because many times what happen, there is some risk of the cancer to come back, but that can be still treated with the curatively, because there is an early or a small recurrence. But because of their loss of follow-up, many times what happens, this small recurrence comes with a very major recurrence, and the patient cannot be cured. So any patient who diagnosed with the cancer should receive optimal treatment as far as the national intervention protocols in a dedicated cancer center, dedicated cancer specialist, and they should uh, come for the regular follow-up, because especially for first 2 years where the risk of recurrence is high. Uh, as far as the breast cancer is concerned, I think people are afraid. They believe mastectomy is the more curative options, because this is one of the major myths about the breast cancer. We've faced this question many times. They believe removal of the breast gives them more curative options, and for two reasons. One, removal of the organ probably cure, they believe, and the second, removal of the breast won't require radiation, because many patients they don't want radiation, they believe. But unfortunately, uh, the cancer, even after removal of the breast, the risk factor of the recurrence is almost the same, because it's not only the breast conservation versus, because breast conservation always come with the radiation to the remaining part of the breast. So the outcome of breast conservation and the mastectomy is the same. The only thing is give a very good quality of life if some women, somebody is having your own breast rather than mastectomy. And as far the radiation is concerned, the radiation is basically, even somebody is in the breast is removed, if there is a lymph node metastasis, then the radiation anyway is going to come. So that is also not right. So that's why nowadays conserving the breast for every woman is the most important tool. And I think unless until there is a scientific reason of removal of the breast, where there is a multi-center disease, more than one tumor, you cannot save the breast, large breast, or the cancer is spread. So those are the situation. The mastectomy is still done, but majority of the patient, I would say more than 90%, the breast conservation is nowadays the standard of care.
Sir, one more question. That is a usual myth for any type of cancer, particularly since we are talking about breast cancer. That is a myth that, because of biopsy, cancer is spreading to the other part of the body or the breast part, etc. Please share your opinion or rather your expertise on this.
I think that is also one of the common myths. So biopsy does not spread the cancer, especially we're talking about the breast cancer. Because the confirmation of the cancer comes with the biopsy only. Because sometimes what happened, there is a breast tumor, and this could be non-cancer also. So doing a breast surgery without confirmation, it is not right. So nowadays, not only the confirmation of the tumor, before doing any treatment, we need to look for the biology. So that is all I mentioned, ER, that is for the biological factor, and that is for must before offering the surgery, radiation, or chemotherapy. So every woman who is having suspicion of the breast cancer, the biopsy confirmation, and also for doing this biological factor, ER should be done. That is the only way the current modality of the treatment. And this is not a right where the doing biopsies spread the cancer. So in breast cancer, biopsy is must, and there's a myth about the spreading of the cancer by doing biopsy.
So one more question. What are the possibilities after reconstruction of the breast?
So reconstruction is a different area. I think where some of the women with diagnosed in the more than one tumor, so there is a tumor in the different part of the breast, and then we need to go for a mastectomy or the large tumor where the mastectomy is to be done. I think those situations there is a role of breast reconstruction because nowadays breast conservation is the most common procedure. But anyway, for any scientific reason, if the mastectomy is done, then reconstruction by your own tissue, that's the one, or even with the now modern implants like silicone implants that is available. So that can be done. So there is a two kind of the reconstruction. One is the immediate, second one is the delayed reconstruction. So most of the breast cancer patients they require a delay because if there is a role of radiation, then uh, uh, this implants is to be avoided initially, but the reconstruction is definitely possible for a majority of the patients, either by our own autograft or with the implants.
And sir, one more question. What is the success rate? What is the success rate by giving immunotherapy to the patient?
That is immunotherapy you're telling, right?
Yes, sir.
So, yeah, for immunotherapy is basically have there is a role in the only one type. Currently, it is approved in the one type of the breast cancer. It is called triple negative breast cancer. So, immunotherapy is basically, in a scientific terms, I can say it is a checkpoint inhibitors. It's a drug which to be given by infusion, and uh, this actually my drug is basically they activate our own immune cells because there is a one pathway is called checkpoint pathway, and with this pathway the cancer cells actually when they deactivate our own immune system. And this drug, what they do, these are the newer agents which are PD-1 and PD-L1 inhibitors. So this checkpoint pathway, they block this pathway so that the inhibition of the tumor cells on the our own immune cells, which is called T lymphocytes, is been removed, and then T lymphocytes become more active and they kills the cancer cells. So this immunotherapy is very popular nowadays, and it is useful for majority of the cancer like head and neck cancer, lung cancer, uterine cancer, intestine cancer, kidney cancer. It's coming in the big way, and currently in the breast cancer, it is approved for the triple negative breast cancer. Even with the advanced stage, even in the neoadjuvant situation where we need to downstage. So it's a big area, and it's combined with the chemotherapy to improve the outcome. So breast cancer is still it is yet to see another type of the breast cancer, but currently it has been approved in a triple negative.
Vaishali, can you check out if there are questions?
Yes, sir. There is a question regarding scalp cooling from Sajid from YouTube. They're asking, um, sir, one disadvantage of scalp cooling equipment can also be that it can cause problems in the working of other cells.
So scalp cooling device apply on the head only. It won't affect in the rest of the body part. It's because wearing of the cap because it's a cold temperature. So sometimes they feel mild headache and some cold injury. So we need to take care by putting a proper protection. Otherwise, safe. So as of now, I would say none of the patient has been discontinued during the treatment. So it is can be done safely and easily for all the patients.
All right, sir. Sir, and a similar question is in the chat box that, sir, I want to ask that is scalp cooling is safe for children? It is asked by Miss Ba Zainab.
So currently, it has been not been for the children. It is only approved for as of now. It's a US FDA, so it is only for the adult patient as of now. And you know that it is mainly for solid tumor cancer patients. So the pediatric population it will not test, and most of the pediatric malignancy is actually the hematological malignancy, or where they require a very frequent administration of the chemotherapy agent. So currently, it is not approved for the pediatric patients.
Okay, sir. And sir, there is one more question. What is the best treatment for breast cancer, and how does diet play role?
So there is no single breast cancer treatment for everyone. So it depends on the patient factor, biology of the disease. So many things are required. The patient stage and biology, and on the basis of that, the oncologist decide which is the best treatment for the patient. So currently, breast conservation surgery, radiation, and the chemotherapy, if the stage is allowed, targeted therapy, even hormone therapy if the tumor is hormone positive. So all the medical management comes based on the patient's individual profile, stage, their hormone receptor, their HER2 status. But most of the breast cancer patients, they require a breast conservation surgery, radiation, and the systemic therapy, which is called medical management. This could be either hormone therapy or combination of the hormone therapy, chemotherapy, immunotherapy, and the target therapy. So situations, case to case basis.
All
And
right.
that is very important, especially during the treatment. If the patient is receiving the chemotherapy treatment, to tolerate with the chemotherapy, optimal diet. So we advise to take uh, uh, plenty of liquids and avoid any outside diet, especially if there is a source of any infection. So hygienic food, more liquids. Raw we usually avoids during the chemotherapy because raw are the source of infections. So otherwise, home food, which is cooked food, is allowed. All the liquids can be given, and raw foods and those kind of things we usually avoid. As far as the prevention, not much data as far as the diet, which helpful, but the only thing there is some association with the obesity and smoking. So I think if you are taking a balanced diet, your BMI is optimal. I think there is no additional risk. So I think diet has a limited role, but definitely during the treatment is a more, and we need to maintain our normal balanced diet to maintain our BMI. So that probably reduce the minimize risk for the breast cancer.
Thank you, doctor. And doctor, there is one more question. Can you shed some light on male breast cancer?
So breast cancer in the male is not that common. So I would say in around 1% to 1%, 0.9 to 1% is the incidence. And most of the time it is associated with the hereditary breast cancer. So the treatment of the male breast cancer is almost the similar, where the removal of the breast tumor, chemotherapy, radiation, hormone therapy, target therapy, as for the standard recommendation. But majority of this male breast cancer are actually triple negative breast cancer, or they are associated with the hereditary cancer. So every male breast cancer patient, we need to look for the hereditary mutation testing to look for any hereditary breast cancer. So treatment is almost the same, and the risk of developing breast cancer is very very low compared to the female breast cancer.
Okay, sir. Thank you.
Uh, so, uh, I'm just about to wrap up. So, dear all participants, we respect the women empowerment unconditionally, and therefore, we are conducting these sessions throughout this month as a breast cancer awareness month, and we will be having one more speaker on next Friday, that is on 18th. He will be clinical oncologist, and then we will have one more speaker, cancer surgeon, on 24th to join us to get answers to all your queries and getting the knowledge. And as always, I am saying in all webinars, if you are not medical professional, don't gamble with your life, and just get in touch with the medical professionals when in times so that your precious lives can be saved. Dr. Ashish, thank you so very much for your valuable time, despite your, heavy commitment and so many things, and enlightening us with the incredible information which are not so easily available and reliable. on been available on web browsers. So thank you so very much, and we look forward to having you once again in the near future. Thank you so very much.
Thank you, Shrenik bhai. And it's my pleasure to be here. And I hope we do such meeting in future also. Thank you.
Thank you.
Dr. Ashish, can I also ask one more question?
Yeah, yeah, sure.
Is right now in the chat box of YouTube. They're asking, how does tumor heterogeneity influence treatment response?
I think this is a very common thing for any cancer treatment because any single patients, the entire tumor is cannot be the same. The tumor heterogeneity it basically leads to a variable response. That's a lead to because so this is one of the most challenging situation where the treating oncologist, even with the spite of whatever the best in the medical management, we may have some kind of the abnormal outcome. So to addressing the tumor heterogeneity, now various tools are coming, and especially in the metastatic setting, now we do a liquid biopsies. We do send a sample for the genetic lab, and based on this profile, we tailor our treatment. So currently, the standard of care we use, but based on this tools, we address because sometimes what happen in a single tumor, there is a different tumor heterogeneity, different outcome at the primary versus metastatic site. So I think this issue would be more effectively sorted out by doing the liquid biopsy, and I think this is the way we can give the best outcome to our patients. And this is one of the major challenge currently because most of the patients still they cannot go for this biopsy. Initially, it was not there, but now the test cost has been cut down drastically, and in our practice, we are doing almost on all patients, so we are addressing this thing and to cope up this thing. So tumor heterogeneity is a common thing for any cancer, but I think the clinician is to take care as much as possible and whatever the best tool for individual patient we need to do, and diagnosis as well as the various therapeutic intervention helps in improving our outcome.
Thank you so much, doctor. Thank you so much, even for your
Uh,
valuable time and all the discussions we had. Thank you, sir.
Thank
uh,
you.
thank you, Dr. Ashish, and thank you, Josa Kovilji, our chairperson, to remain present during this commendable session.
Thank you. See you.